Good afternoon, everybody, and welcome to our midweek COVID update of the 20th of October. So it is quite an important day today because today we're starting the kickoff of the adolescent vaccination program, the adolescents from the ages of 12 to 17. And I'll come to that just now. So let me go straight on to our usual update information. So where are we today? The usual curve, nothing very much changed as compared to last week. Curve coming down nicely. We're now really at the bottom of the curve in the interwave period of relatively low transmission of the virus. And certainly you look at some of these parameters. If you look at the proportion of tests which are positive, it's a very low figure. 2.7% is really taking us back to the early days of the pandemic, and certainly quite a bit lower than the interwave period between the first, second and third wave of the waves. So that's pretty good news. And also, if you look at the hospital admissions in the different provinces, again, coming all the way down. So all these parameters are looking pretty good. We're not totally out of the woods. If we look at the daily cases, it averages between about 400, 500, 600 as a 7-day moving average, new cases every day. So there is still some virus transmission. There are still some cases, but fortunately at a pretty low level. And also looking at the solid data over the last week, there are 10 new cases, 33 still on treatment or being managed in the home monitoring program, being active. So not totally zero, but certainly a fairly lowish level of cases. But going to emphasize what I mentioned last week, there is virus transmission. There are new cases. The virus hasn't really disappeared. It's still around and it's still lurking there. So again, to emphasize that it is essential that we do still maintain all the infection prevention precautions, the masks, the distancing, the avoiding of gatherings, and hand sanitizing. So please, even if you've been vaccinated, please carry on with, because there is still COVID. We are awaiting for the fourth wave, and really how the general national human behavior pans out. So that will, to a large extent, also govern when, where, and how the fourth wave will take place. All right, let's talk a little bit about the vaccination status as it was yesterday. So we've reached the 20 million doses being administered, just over 20 million, 20.5 million doses have been administered, and 14.3 million people have been vaccinated, either fully or partially. So 36% of the adult population over the age of 18. We're going to have to adjust these figures now as we've lowered the age of vaccination, but up from 18 plus is 36%, and total population, including all children, all the population, including children, 24%. So coming out to about a quarter of the total population have received vaccine. This is the breakdown according to doses of those who've been fully vaccinated, in other words, received either a Johnson & Johnson vaccine or 2 doses of Pfizer. And this is the number of people that have received 1 dose of Pfizer, partially vaccinated. So if we look at the percentage adult population coverage, the Western Cape still leading the pack at about 45% of the adult population of Western Cape having been vaccinated, followed closely by the Eastern Cape, the Free State, and Limpopo. And unfortunately, Gauteng still lagging a bit behind. We've still got a bit of a way to go. But also wanted to point it out, if we look at the key age high-risk population, the 60 pluses, 62% of this population, 60 pluses, have been vaccinated, either fully or partially. And that's, of course, really what we want to really focus on. That's the high risk. So even when I'm going to come just now to the adult or children vaccination, our priority and the main effort is still being focused on the older, high risk age groups, 50 to 59 at 54%. If you look at that same age group who've been fully vaccinated, It's a little bit low. It's 53%, but still advancing. We still are progressing, but a substantial gap still need to be filled. 53.16% of 60 plus in the population have been fully vaccinated. And between the 50 and 59-year-old age groups, it's 46%. A little bit of a worry still with the daily vaccination. We're still well below our 250,000 doses per day target, which we need to get to if we want to immunize the adult population, the total adult population of 18 years old and plus by the end of the year. I personally don't think we're going to get to that. I think it's probably going to stretch into the early months of next year before we reach that target, that particular target, 70% of the adult population. All right, I've had a number of questions from all of you with regard to the vaccination of the adult. I'm going to call them adolescents rather than children, because it is really adolescents, the 12 to 17 years old age group. And the obvious question is there been a change of policy? In the early days, we kept on saying, and we did rightly say, that children would play a very minor role in the overall epidemiology of the pandemic, and also that children are very much less likely to get severely ill. Well, the latter still does apply. Children are very much less likely to get severely ill, but they do still occupy a certain number of cases. For example, you look at the percentage of new cases in children under the age of 19, it's 10.2% of new cases on that age group. 4.2% of, actually, I've got a slide of this easier. 10.2% of new cases in children under the age of 19, 4.2% of hospitalizations occur in that group, and 0.7% of deaths. But children certainly do clinically fare much better than the older age group. Interestingly enough, what has changed is, of course, the prevalence of the Delta variant, because the Delta variant is, of course, substantially more contagious, more infectious variant, and it has penetrated to a much larger extent in the younger age groups, causing cases, causing hospitalization, and also being important in terms of the transmission. So if we look at the third wave, which is driven by the Delta wave, 14.6% of cases were in this age group, as compared to the first and second waves, driven by the ancestral and the beta variant, 9% of cases. Now, in addition to children playing an important role or having a substantial role, shall I say, obviously very much less in adults in terms of being hospitalized and so on. The important thing in terms from the epidemiology, in terms of children as a source of infection, let me just have a couple of words on that. Certainly, if we look at the very young, we look at toddlers, for example, they are probably not an important role still, even with the Delta. And I think I've explained in the previous reason, there is a physiological reason for that, because they have very much less of the receptors for the virus. They haven't matured yet in their upper respiratory tracts to be an important reservoir of the virus, and therefore to transmit the virus. That's in the very young, talking about the toddler age group. Once we advance, say, for example, to the 15-year-old adolescents, they are as infectious as adults, as the older adults, with the Delta variant. And this is really what has changed strategy. Because of the prevalence, because of the force of the Delta variant, that has now changed quite substantially the strategy throughout the world. So the vaccine has been licensed now throughout the world by the FDA, WHO, the European Medicine Authority, and so on, have all now licensed vaccines for 12 to 18-year-old groups. And of course, in much of the developed world, children are part of the vaccination rollout. So that was really the kind of reason. Of course, we're also being asked why only one dose at this stage. I think the one dose, I think, also emphasizes that the priority must remain, and re-emphasizing it, the older age, the older adults, the 60 plus age group, the 50 plus age group. They still remain the priority over the adolescents. So at this stage, we're going to use one dose. And you must remember that the interval between the two doses of Pfizer in this country is 6 weeks. The United Kingdom is 12 weeks. So the interim period, we'll wait to get more data from programs overseas and also observe what's happening in this country. And I'm sure that the second dose will be introduced for adolescents in the early part of next year. But at this stage, it's one dose, which gives pretty good protection, particularly against severe disease, where it's up, in fact, about plus 90%, 93, 94% protection against Delta virus causing severe disease. I've also been asked particularly by some medical colleagues, the risk of myocarditis. Myocarditis is an inflammation of the heart muscle. Now, there's been quite a lot of media publicity about myocarditis. Let me emphasize it is a rare complication, It occurs mainly in boys, in fact, in boys and male adolescents and male young adults, about at least 3 or 4 times as compared to females. In fact, in some even higher ratio in males than in females. And almost always after the second dose, not after the first dose, and usually within about 10 to 14 days after receiving the second dose of the vaccine. But the incidence, the kind of biggest studies been done in Israel, and they put it at 24 cases per million recipients following the second dose. So as you can see, it's very rare. American statistics, 19,436,000. Another Israeli study, 2.13 per 100,000. Very rare. As compared to COVID infection, the risk of myocarditis, infection of the heart, is 16 times the risk of non-infected individuals. So COVID infection itself carries a substantial risk, much, much higher than risk following the vaccination. So I think another very important issue with myocarditis is that it is the vast majority of the cases which have been found being very mild and self-limiting. In other words, without any problems afterwards, and these boys usually recover pretty well. So it's a mild, rare complication. Allergies, I've also asked a lot about allergies. Well, you know, I think it's important to notify the vaccination site that there is a history of allergy in a particular adolescent. And as we advise for adults, they should wait, instead of waiting 15 minutes after receiving the vaccine, wait 30 minutes. Take a good book or take homework with and do your homework while you're waiting the 15 minutes after receiving the vaccination, and make it half an hour instead of 15 minutes. Allergies are very rare, also extremely rare. Minor allergies may occur, for example, around the vaccination site, but certainly the more severe allergies, what you call anaphylaxis, also about 1 per million dose, very, very rare. And also history of allergy to flu vaccine and other things doesn't necessarily mean that there's an allergy to the Pfizer vaccine. Another interesting question which I have been asked regard to adolescent vaccine, if an adolescent gets their first dose now, and then they turn 18 soon afterwards, can they then get their second dose? And yes, the answer is yes. In other words, the EVDS system, the electronic vaccine data system, will pick up their age. Once they are 18, they then go into the category of the 18 pluses, and they will then get their second dose then. Can a scholar play sport after vaccination? I would advise wait to about 3 or 4 days after vaccination, for no other good reason than there is some adolescents who will get minor flu-like illness, might feel a bit out of sort, might be pain in the arm, and so the usual as with adults as well. And it may be advisable to kind of maybe not indulge in strenuous sport for 3 or 4 days after getting the vaccine. And then lastly, how long does it take to get immunity? I'm asked this because it's important for those who want to go to camp, to Machane. And the longer the interval after the vaccination, so the immunity will mature. And I've put out a request to the camp organizers to try and get their chanechim. By the way, only those who've been vaccinated will be allowed to go to camp. That they should be immunized as soon as possible. So there's a generous period of time after being vaccinated before they go into camp. Just to quickly go through some of the other questions which have been raised other than the adolescent vaccination. There's one question about air purifiers. Well, the air purifiers, the general air purifiers don't filter out the virus. There are specific filters called HEPA filters, HEPA, high efficiency particle air filters. Those are put into industrial air conditioners. They're obviously in the hospitals, in aircraft, for example. And these do filter out viruses, including the COVID virus. But other air purifiers, which don't have as close a mesh in the filter, will not filter out viruses. It's only the HEPA filter, HEPA filters, which have got a close enough mesh to filter out viruses. Then the question about safety of air travel. Look, the air in airplanes are filtered through HEPA filters, through HEPA filters. But obviously people sitting right next to one, or the road in front, the rows behind, they do pose a potential problem. But I think with all the precautions of the wearing of the masks, keeping physical distance, I don't think there's anything intrinsically problematic with air travel, either local or international travel. It really is the same kind of precaution to try and keep physical distance, wearing masks properly, covering the nose and the mouth. And then it's the same risk as in any other environment where people are congregating. I was asking about, should there be a vaccine mandate for people attending a house of worship, a shul, for example? I really can't advise a policy. Obviously, it is a situation where people do congregate, where people are singing. In some situations, they might be eating, and therefore the mosques come down. So it would be advisable as a general public health principle to have a vaccine mandate. But whether it should be universally applied, I think that's a policy decision which individual houses of worship controllers would need to kind of make that decision. And then lastly, the issue about taking temperatures as a screening. You know, this really originated, this mass temperature screening, when there was a scare of the viral hemorrhagic fevers, you know, the very severe disease which happened in Central Africa and West Africa, and also in the flu pandemics, where the idea was that you take a temperature, have a temperature screening, an infrared temperature screening device, and you could screen lots and lots of people coming through an airport, for example, and pick out individuals who are ill. And then the idea was to extrapolate that as a screening procedure for COVID. And really, it's really been abandoned, I think, in most situations. It's extremely, I've never ever heard, in fact, that they have picked up a person with COVID through temperature screening. They may well have. It hasn't been reported in literature as far as I've seen, and I've never been reported to me that they've ever been able to pick up a person with a high temperature in the COVID screening. I'd imagine that somebody who's got a high temperature as a result of COVID would be pretty ill, and I think won't be able to pick it up without temperature screening. So I don't think there's any point. I think it's a bit of a waste doing temperature screening. More important is history screening. In other words, to ask the person, have they been in contact with a person with COVID? Or have they been feeling unwell? Those kind of screening procedures would be much more effective than temperature screening. So thank you very much for listening and viewing, and we'll see you next week. All the very best. Have a good week. Stay safe and stay well. Thank you. Bye-bye.